Good morning, everyone, and a big thank you to whoever's made it for today's first day, first session of this test match series. Can we have the presentation, please? So many thanks to speakers for making it here on time at 8 in the morning, and a big thank you to the delegates who managed to reach here and take part in this unique instruction course, which we've called as the Kochi Glaucoma Debate, or the Ultimate Face-Off. I'm Dr. MAYAV MOVDAWALLA. I'm the chief instructor, and I'll be giving you a brief introduction and a scope or the need for this particular debate. No financial interest in the following presentation. So we all know glaucoma is an ambiguous disease. It's a gray disease with no absolute black or white. There are vast modes of presentation in glaucoma. You may have somebody walking into your OPD absolutely asymptomatic with no complaints whatsoever and may have advanced disc damage in glaucoma. And on the other end of the spectrum, you have somebody walking in with a swollen, red, painful eye, vomiting all over the place with pressures of 40 and 50, and yet having an absolutely healthy disc. Vast number of diagnostics tools, measuring RNFL, disc parameters, perimetry, and of course treatment options. Treatment options, again, from one end of the spectrum where it could just be a simple wait and watch to advanced glaucoma surgical options which are there. So the treatment outcomes vary from patient to patient, and there is no one-size-fits-all strategy. It has to be highly individualized, and the treatment depends again a lot on the surgeon or the consultant's own practice pattern and experience. Hence the need for a debate-minded approach for certain glaucoma, scenarios in glaucoma, where both sides of the coin are assessed and discussed. So the first debate of the day is the age-old conundrum of structure versus function. A structural test looking for glaucoma-related optic nerve damage, especially thinning of the RNFL, form a very, very important part of glaucoma diagnosis and management, and used in tricky conditions, especially like pre-perimetric glaucomas or disc suspects. We have vast variety of, again, structural tests, ranging again from basic disc photographs, stereoscopic disc photographs, disc diagrams, RNFL measurements. Earlier we had the HRT, the GDX, and newly the OCT angiography. But what is the utility, we shall discuss. Again, functional tests, especially perimetry, form the backbone of glaucoma armamentarium, from diagnosis to progression as the must for every patient. Now, are structure and function supplementary or complementary to each other? We will try to see that in the first debate of the day. Our second debate is the role of anti-glaucoma medications versus minimally invasive glaucoma surgery in glaucoma-controlled patients undergoing cataract surgery. We all have a large number of patients who are on medications undergoing cataract surgery, and the standard of care for many of them has been just to do the cataract surgery and continue the medications for them. Now, should we maintain status quo or try something different? We all know MIGS is the new kid on the block. We have bent ab interno goniotomy, KDB goniotomy, or the eye stent. So in this second debate, we look at this, whether anti-glaucoma medications versus MIGS in these situations, looking at the pros and cons of both approaches, most important, looking at overall impact on cost and quality of life. And our third debate is role of trab versus tube in first-line surgery, as a first-line surgery in primary glaucomas. Trabeculectomy has always been the gold standard for surgical management of primary glaucoma. It's cost-effective, relatively easy leaning curve. However, early and late complications make it unpredictable in the best of hands. Tubes, as we all know, either wired or non-wired, are the mainstay in secondary glaucomas, but can be used in primary glaucomas as well, which the primary TVT study has shown. So in view of the fact of documented fewer vision-threatening complications, is it prudent to shift our approach or stick to what works best in our hands? So this will be the point of contention in a third debate of the day. So each speaker will speak for 7 minutes. We keep the discussion as clinical and relevant as possible. We'll take questions at the end. And let's hope for a fruitful and no-holds-barred debate session for the day. And for the first speaker, I would like to call Dr. Nagalakshmi Ganesh, who was our colleague in Shankar Netralaya as well. And she'll be speaking in the role of structural tests. And she'll be going on head with our guru, teacher, everything possible for all of us from Netralaya, Dr. Ronnie George. Nagalakshmi, please. Seven minutes, Nagalakshmi.
Good morning, everyone. I'll be talking about the role of structural tests for glaucoma diagnosis and progression. The current glaucoma definitions by major glaucoma societies include the loss of retinal ganglion cells, which is essentially a structural measure. So we have the clinical assessment, disc photography, which are more of a qualitative test, and HRT, GDX, and OCT, which are quantitative. So where do structural tests outscore functional tests, and why is it the case? Various studies have shown that structural evaluation is a more sensitive measure of early glaucoma. Of note is Kerrigan et al.'s study in 2000, where it was noted that at least 25 to 35% of RGC loss is required before SAP abnormalities develop. Why is this the case? Because there is a redundancy of the visual system, which means in early stage of glaucoma, the neighboring retinal ganglion cells which are functional compensate for the cells that are dead nearby. So a significant structural change translates to only a smaller relative functional change. And again, the structure-function relation has been known to be curvilinear until a tipping point, until which the abnormalities are primarily in structure, followed by measurable changes both in structure as well as function. So even as early as 1991, among the OHT cohort of 1,344 patients, it was noted that in 60% the RNFL defects were detected by red-free images 6 years prior to visual field changes. Talking about the photography, it is the most commonly used method of documenting structural change, and it has also been used as an endpoint in various major randomized controlled trials. And the qualitative variables which are documented by the photographs have a higher specificity than the quantitative parameters. So this structure-function discord causes, the concept of pre-perimetric glaucoma, where there is a presence of characteristic glaucomatous change without presence of visual field defects. So of note is the study by the advanced imaging glaucoma study, which was a multicentric longitudinal trial which went on for 9 years, and this had the maximum number of pre-perimetric glaucomatous eyes of about 663. And it was noted that there was a significant difference between the normal and the glaucoma suspects, and also the perimetric glaucoma groups in all the measured diagnostic variables except for rim area by HRT and overall nerve fiber layer thickness by the GDX. Also, the repeatability was noted to be best for the nerve fiber layer thickness and GCC by the Fourier domain OCT. However, a study from Shankar Netralia published in 2021 on pre-perimetric eyes showed only a significant difference in the following parameters, which were average RNFL thickness, inferior RNFL thickness, infratemporal GCL IPL thickness, average and minimal GCL and IPL thickness. So talking about the ganglion cell complex, it includes RNFL layer, GCL and the IPL. The new parameters like focal loss volume and global loss volume have better diagnostic values, especially the global loss volume have a higher odds ratio in early glaucoma and FLV in detecting even advanced glaucoma cases. Also, it has an edge in high myopic eyes, where it is less affected by axial length parameters and also circumvents the variation with ONH and peripapillary parameters. So talking about the role of structural test in glaucoma progression, we know a change that is when it is more than what is expected with aging and test-retest variability, we classify it as progression. Again, the advanced imaging glaucoma group went on to state that the visual field conversion was preceded by abnormal OCT in the pre-perimetric group by at least 2 years. The detection rate was definitely more with the structural test being about 38.9% versus only 18.7% by the functional test. And GCC and NFL parameter combined had a significantly better detection rate than trend and event analysis combined. Also, surprisingly, while the NFL detection rate by NFL dropped in late glaucomas, by GCC remained fairly constant even in the later stages. So the same group published the data on perimetric glaucoma. Again, highest odds ratio was noted for nerve fiber layer and focal loss volume, especially in rapid progressors. Also, disc hemorrhage was known to have a higher odds ratio. Talking about disc hemorrhage, the odds of disc hemorrhage causing progression, the presence of disc hemorrhage in rapid progressors were higher when it was present along the neuroretinal rim or along the area of nerve fiber layer defect. So there were also similar other studies which prove the role of structural test in detecting progression, especially in early pre-perimetric and mild glaucomas, much earlier than the functional test. So why should we detect glaucoma early in these cohort? It's because like every millimeter of IOP does matter, as proved by Kim et al. Study in American Journal in 2015, where they studied 127 eyes, and it was noted that 56.7% of them progressed, and the cutoff value of 22.1% of IOP reduction best differentiated progressors from non-progressors. And considering that the progressors dropped by about 0.6 decibels of mean deviation every year, it would take about 15 years for the progressors to develop advanced disease. Also, in the light of landmark studies, we know that IOP reduction is of paramount importance. In fact, AMGT has shown a hazard ratio of about 1.1 per millimeter of mercury. So the popular arguments that are touted against the structural test is the red disease, which is because of high false positives and the low specificity. Again, this knowing the basics really helps in differentiating red from real disease. That is a thorough knowledge of the normative database of the machines that we are dealing with. A systematic approach to OCT interpretation, especially concentrating on clinical correlation, and knowing the artifacts which the OCT can produce also helps in combating the red disease. Also, the other argument would be the floor effect. It is now known that the papillomacular bundle is more resistant to damage, and hence GCL-IPL shows the potential to identify structural progression even in advanced diseases, which decreases the impact of floor effect. So how does the functional test score as far as the advanced glaucoma is concerned? So it's been stated that when the mean deviation loss is less than 20 decibels, again, the test-retest sensitivity fluctuation is much higher, as seen by the coefficient of variation, which is about 13 to 28% with visual fields. So the other limitations with the functional test would be that it is subjective, and we know subjectivity is a bane of any disease management. Interpretation is complex due to complex jargons like learning curve, variability, false positives, negatives, artifacts, fluctuations, etc. And also the other other functional tests like SWAP, FTT, and ERG have not stood the test of time. 24-2 undersample central field, 10-2 does not have a GPA functional test. Though visual fields is a functional test, there is no importance to quality of life parameter, and this does not address the pathomechanism of glaucoma per se, and it's a relatively stagnant technology when compared to the amount of development that's been happening in the structural tests. And also patient factors like when there is a limitation to perform, and it's quite time consuming and tedious. Some of them even put away follow-up considering the performance pressure. So the recent advances would be OCTA, which addresses the vascular pathogenesis, and the Brooks membrane opening, which is a more accurate measure of the neuroretinal rim, and RNFL reflectance has been shown to be reduced in early glaucomas. Again, of interest is the lamina cribrosa imaging, which is again a part of the mechanical pathogenesis of glaucoma. So we have the artificial intelligence and okay, so the take-home message is structural tests have a valuable role in the detection of preperimetric, mild and moderate glaucomas. They only supplement clinical optic nerve assessment and should not be used in isolation. Red, if read well, can be real. Due to the structure-function discord, it is recommended to monitor progression with both structure and functional test. So the newer structural tests have allowed for understanding of the pathomechanisms of glaucoma per se, so it is tried, tested, and also new. Thank you.
Thank you, Nagalakshmi. That was extremely well researched, and so she's made your job, I think, slightly tougher. We have Dr. Ronnie Jogsnest, who's Director of Glaucoma Services in Shankar Nethralaya, Chennai, and he'll be speaking on the role of functional tests in glaucoma diagnosis and progression. Welcome, sir, and thank you for again being part of this instruction course.
Thank you for the invitation, MAYAV. It's nice to be here among friends. And so Nagalakshmi has given me a lot of things to try and rebut, and let me see what I can do with that. So I'm going to speak about curves, I'm going to speak about technology, and I'm going to speak about what actually matters. And when we talk about structure, she's already defined what this is, so I'll let that be. She's already shown you the slide, and this is the curve I'm talking about, this curvilinear slide that everybody says that, you know, this is what happens. Threshold values drop late, but the reason this happens is because as physicians, we are mathematically challenged, and we could not deal with the huge numbers of apostips. So what everybody does is they just convert it to log, so we now have to deal with numbers only from 0 to 40, and we are happy with that. What happens when you transform this again? When you transform this, you will see that, take. When you see this, so this is what the curve looks like. You transform this in two ways. You can either transform the logarithmic to linear, or you can transform the linear to logarithmic. Both ways, you will see an absolutely straight line. So it's actually a linear relationship between RNFL loss and threshold loss. The problem is, even though they change similarly in glaucoma, our inability to detect very early change is probably a result of the limitation of technology and physiological variations, and not really because of what is happening in the disease. So now you think I've already handed over the debate to her. But the fact is that if you want to pick up every single patient with glaucoma on a structural test, you will require 20 to 30% ganglion cell loss to be able to do that, which is very similar to the number that she showed you for visual fields. So it's a bit of a caveat. If you want to diagnose glaucoma, both are equally good or equally bad because of these two reasons. And she spoke to you about red disease, and this is the problem with imaging. You'll end up with something like this. You look at it, there's red all over the place, but all of us sitting here as glaucoma specialists will tell you that's a large disc, there's nothing much to worry about it. But people who are not glaucoma specialists would be concerned, and this is what the field looks like, this is what the other eye disc looks like, and this is what the field looks like 3 years down the line without any treatment. Nothing is happening there. What about fluctuation on perimetry? And she did allude to that, saying it makes it difficult to assess progression. So I'll share with you the European glaucoma optic disc appraisal study for progression. So 88 ophthalmologists were given stereo photographs of 54 eyes, and they had to decide whether these were stable or progressing. And this was the agreement between glaucoma specialists. So we could not agree with each other also whether the disc is progressing or not. So in terms of fluctuations on perimetry, we'll talk about fluctuations in assessing progression. And this is somebody whom we have who is, got fairly long follow-up, and those are what his OCTs look like. And what I would like you to look here is at this bit. The RNFL thickness progression map is actually showing an improvement. Not possible, right? So you talk about fluctuation on perimetry, you get fluctuation on the OCT too. So glaucoma progression, when you look at structure versus function, and I'm not going to talk to you about this. This is a study that we did at SN. It's unpublished, so it's a little unfair to you. But what I will just show you is that we were looking for progression on the OCT, on the GDX, and on the HRT versus visual fields, and this is what we found. We found that the maximum number of people showed progression on the HRT and the minimum on the visual field. And for the visual field, we use a progressor software, which is actually a point-wise comparison, which is pretty good. But what's interesting here is, if you look at the OCT progress group, nobody progressed on the other two tests. If you look at the HRT progress group, one person in that group progressed on the GDX. If you look at the GDX progress group, nobody progressed on the other imaging tests. So they don't even agree with each other when it comes to whether somebody is progressing or not. So I've shown you that assessing structural damage is not the same with different devices. It's not the same with different OCTs. And the normative database is important, like she mentioned. And what the most important question to me is, we don't know what's the normal rate of RNFL loss. So whatever change you're seeing, is it because of age or is it because the disease is getting worse? And that's information we don't have. And this is something like my journey in ophthalmology. I joined in 1996 when OCT was involved. Second generation came out in 2000, third generation in 2002, fourth in 2006, and now you're looking at the swept source OCTs. And the nice part about it is, none of them are backward compatible. GDX came in 92, and by 2015, HRT came in 91, stopped production 2 years back. They claim they're going to support you, but it's on the threshold. So basically, these machines are going to be resting in peace, while our glaucoma patients are going to continue to need to do a new test on a new machine to figure out what needs to be done. And this is just one of our patients, and you can see we have something like 12 or 13 years follow-up on him. And These are his HRTs over time. And now I have to try and get a new baseline on him because the HRT is going to go out of place in here, but the fields are still okay, the fields are still backward compatible by 15 years. So my argument is that function is more important than structure. It does not matter what it looks like, as long as it works. And I hope that I managed to convince you of it, even though in this case, structure looks much better than function. So, thank you.
Thank you. Saib, are we ready? Yes, please. So our second debate for today, thank you, sir. Our second debate for today is role of anti-glaucoma medications versus minimally invasive glaucoma surgery in glaucoma-controlled eyes undergoing cataract surgery. Dr. Sahiba Sethi is senior glaucoma consultant in Gurugram in Arunodaya Deseret High Hospital. She's a colleague, and she's one of the most prolific mixed surgeons of India as of now. But she's still speaking on...
We can't start with the debate with that introduction.
She's speaking on anti-glaucoma medications, which is, which is amazing. So, Sahiba, over to you.
Yeah. So, good morning, everyone. Yes, I do agree with MAYAV that I do mix myself. But anyway, I think the point of my debate would be not exactly what is good or bad, but what applies where. And both our previous debaters have been very civil, so let's see how this one goes. Can we start? So, I'm going to be speaking about why anti-glaucoma medications would be preferred in certain cases who are undergoing cataract surgery but are controlled, their glaucoma is controlled on anti-glaucoma medications at present. So, we all know that MIGS can be performed only in mild to moderate open-angle glaucomas, pseudo-exfoliation and pigmentary glaucomas, wherein you need about, let's say, mild to moderate drop in intraocular pressure, with your target IOP being about in the mid-teens and an open angle. But then what about all the others? You wouldn't dare do MIGS in them. So not all patients are eligible for MIGS is my first argument. There are plethora of limitations here. Patients who have inadequate visualization as in corneal opacities, patients having peripheral anterior synechiae, all other forms of glaucoma apart from the ones that I mentioned, MIGS is contraindicated. It has been tried extensively in primary angle closure glaucoma. However, any of the devices are not licensed for use in PACGs. Also the fact that MIGS cannot attain pressures lower than the episcleral venous pressure, which means nothing less than 8 to 10. So in cases where you need a very low IOP like in advanced glaucomas or NTGs, MIGS, at least the types that are available in India are not applicable. Now, if you're promising your patients medication-free life post their cataract surgery, what you're achieving with MIGS is basically just targeting one mechanism of action. That probably explains the moderate to mild drop in intraocular pressure. If you do want an additive effect, you have to anyway start the patients on AGM over and above the MIGS. Now, what about also patients who have difficulty in positioning their heads in the way that MIGS requires them to do? Patients with cervical spine, stiff neck. What about patients on anticoagulants? You can have devastating intraoperative, postoperative bleeding in MIGS versus just continuing AGMs. Now, also the fact that there is inevitable learning curve, especially in India, wherein MIGS is new. We're still, we have a lack of expertise in using surgical gonio-prisms, and offering MIGS without guarantee, I think, would be a mistake. So, complications like underimplantation, overimplantation in if you're going in for an eye stent inject. This is also a very interesting video which I have taken with and sharing with permission from the primary surgeon. So here what I want to show is that this is a bang procedure which is being performed, and the excision is actually happening at the root of the iris, not at the trabecular meshwork. So basically, we are all learning MIGS, we're all learning surgical gonioscopy still. So misidentification of trabecular meshwork, improper level of excision. So these are all complications that we have to realistically accept before offering them to our patients. What if also you encounter a complication with your cataract surgery? So none of the MIGS procedures have been studied on their efficacy in the setting of complicated cataract surgery. So if you do encounter PCR, or even as much as placing the IOL in the sulcus, the efficacy of MIGS or all the published literature is not investigated for situations like these. So what do? You have no choice, you abandon and continue AGMs. This is a case of my own wherein there was a complicated cataract, and I had planned the bang post the cataract surgery. The cornea became edematous. As soon as I took the first snick, there was bleeding. There was absolutely no visualization from there on, and I had to abandon the surgery. Then again, the overemphasized aspect of the cost of the surgery, wherein a patient on AGM will be spending about, let's say, 60,000 in 5 years. He would be doing it in one go when choosing the more sophisticated options of MIGS. Also, we lack good insurance cover in the Indian scenario at present. Now, what when you're using premium lenses? That wow factor is lacking on the first post-operative day. This is a patient with an uncomplicated cataract surgery, and a Kahug dual blade was performed, and it was an absolutely uneventful surgery. But what ended up happening on the first post-operative day was the anterior hyaloid face was full of iris pigments. So like I said, that with a higher cost of surgery comes high expectations. So if your patients are stable and they are well controlled, that means the patient is having no compliance issue, no tolerability issues, the glaucoma is stable. So what are you basically promising to your patient? Are you promising AGM reduction? Are you promising medication-free life? So the patient thinks, great, I have less drops to deal with now. But how many drops will you reduce? Can you promise the patient? No. How long will the effect last? So the patient thinks, oh, I thought that my surgery went well, but now I have to be starting on more drops. Will I require more surgeries? What amount of IOP reduction? What surgery to use on which patient? So all of these are questions that we just cannot answer because we do not have evidence. Like I said, we do not have long-term evidence on safety and efficacy of MIGS procedures. There is no head-to-head comparison on between different MIGS procedures also. And phaco itself reduces the IOP, although marginally, especially so in narrow-angle glaucomas. And let's not forget that glaucoma is a progressive disease. Doing MIGS today will still not ensure that you are not on anti-glaucoma medications a few years down the line. Therapy keeps escalating. Now, you may argue about ocular surface disease. Well, again, now, you have preservative-free options for anti-glaucoma medications, and also there is a huge deficiency in the literature wherein, there is improvement in ocular surface disease after MIGS also. And also when talking about quality of life, I think because we have data only less than 5 years worldwide on any of the procedures of MIGS or devices of MIGS, improvement of the quality of life can only be measured over 5 or 10 years, which will take into account how many additional AGMs were added or how many patients underwent future surgeries. So, in my opinion, in summary, I think AGMs, they give you no guarantee of freedom from AGMs. MIGS give you no guarantee from freedom from AGMs, and they should only be tried in very motivated patients because expectations are high, results are unpredictable, and frankly, it only buys more time before restarting anti-glaucoma medications. Thank you.
Thank you, Sahiba. That was indeed very compelling for use of anti-glaucoma medications. And now we have Dr. Amit Pandey, who's a senior glaucoma consultant in CFS Surat, a very close friend and colleague, and again, one of prolific MIGS surgeons of India. And he'll be speaking on the role of minimally invasive glaucoma surgery in these eyes.
First of all, The topic is controlled glaucoma undergoing cataract surgery, right? So advanced glaucomas, very high intraocular pressures, that doesn't matter in this debate, right? And no data, lack of data, that would only get solved when we do MIGS, right? So again, we have to do MIGS. Chalo, we'll start. Thank you, MAYAV, for this, for calling me here and for this wonderful opportunity. What was the other point? Anyway, what was the other point? Let's have a discussion.
No, wait. We're just starting a presentation.
Again, NVGs and secondary glaucomas, again, in those cases, you're not going to put medications, right? NVG, you have to operate. So, what else was the point? Cost was the one. We have bang, low cost, 10 rupees needle that you need to. And complications will happen with any surgery. Complications will happen with medications also, right? Of course. Right. So how do we solve that? Give me on that laptop, no? Pen drive.
No, there's an issue with the LED screen, not with your laptop or the pen drive.
How much did you pay?
One toffee.
Now it's fine. So first of all, I don't have any conflict of interest. You can check my pockets. We know all this. We know glaucoma is the leading cause of irreversible blindness, and we know 90% are undiagnosed. But even those who are diagnosed, the treatment right now is lacking. 53% adherence issues in 6 months. What we are doing now is majority of our patients are on medications. And when it becomes advanced severe glaucomas, we do a trabeculectomy. When that fails, we do a tube. When that fails, we do cyclodestruction. And medications, we have so many varieties of medications. That's not the issue. The current scenario of glaucoma management is lacking, and that's why so many of our patients, especially in our country, are progressing into severe and advanced glaucomas, losing their vision. So lack of a variety of medications is not the issue. The need of the hour is to prevent these mild to moderate glaucoma patients from progressing into severe visual impairment, and to do this with a minimally invasive or a low risk method. We know these problems with medical management, compliance being the biggest issue. 40-60% of our patients don't adhere to their prescribed medications, and it worsens when the patient is on multiple medications. Ocular surface disorders, systemic side effects like cardiorespiratory and metallic taste, poor quality of life with multiple daily dosage, dependence on other family members, fluctuations in the intraocular pressure. Benefit of surgical management, again, we know this, more stable intraocular pressure control, lesser visual field loss, lesser adherence and compliance issues, lesser red eye and ocular surface disorders, better quality of life overall, and surgical patients, they tend to take their disease more seriously. So we get better compliance and regular follow-ups in these patients. Surgical options that we have is more for the severe and refractory glaucomas before the advent of MIGS. We did not have anything for mild to moderate glaucomas because the risks of filtration surgeries outweigh the benefits in these mild to moderate glaucomas. But now we have MIGS, which can fill this gap between medications and trabeculectomy very effectively and very safely. That's the point. Safety is the biggest advantage that MIGS is giving us. So we have so many options now. The iStent Inject, we have the trabectome, KDB, the GAD, the suture GAD. We have low cost, we have medium cost, we have high cost alternatives as well. So where do we have to do MIGS? In mild to moderate glaucomas undergoing a cataract surgery, open angle preferably. Majority of our patients are open angle. The counter of secondary glaucomas are 10%. What about 90% of our patients? Patients who are on multiple medications, patients on having allergies to medications, contraindications, non-compliant. If we know that the patient again and again comes, stops his drops and comes, we have so many of those patients. Patients relative coming and telling us he's not putting his drops properly. Patients themselves coming and saying, I forgot my drops. So what about those patients? Patients who are keen on getting a glaucoma, they want to get rid of their medications. Those patients, now we have an option. In special indications, we can also do, we have tried in post-filtration surgery when the intraocular pressure requirement is not very exorbitant, because here the conjunctival scarring is irrelevant. We are doing an angle surgery. Patients with scleral thinning staphylomas, which bars any filtration surgery, what do you do there? Even congenital developmental glaucomas, this is a very, very good option. We have been doing angle surgeries in congenital glaucomas for so many years. Angle closure, if it opens up after the cataract surgery, so many of patients are having occludable angles, and that will open up after the cataract surgery, and we can do a MIGS in those patients. Let's see an example, a middle-aged guy with significant cataract, open angle, mild visual field loss, allergic to brimonidine, asthmatic, so timolol is contraindicated. Without MIGS, we would have done a cataract surgery and controlled him on 2 medications. But now we have the option of doing a MIGS. So we do a eye stent. I'm not going to show you the details of the surgical details. This is how the eye stent Gen 1 looks like in the angle. This is first post-op day, cataract surgery, crystal clear corneas, 6/6 vision, at 6 months follow-up, 14-16 pressures without any AGM. If we can give this to our patients, this is wonderful. Again, eye stent Gen 2 surgery, I'll not show. We have Kahook's dual blade, which is so easy to do. It's just a 2-minute procedure that we can do after the cataract surgery. And learning curve is not that difficult. The point of learning curve that Saiba raised, it's not difficult. We have been looking at the angles day in and day out on the slit lamp. It's much more easier to see it on direct gonioscopy because we are seeing it directly. So we as glaucoma surgeons are the best people to do angle surgeries. It's such a simple procedure. You get the trabecular meshwork in your hand. It's so satisfying. You see that? That's the trabecular meshwork strip. It's so satisfying to finally hold the trabecular meshwork in your hand. And the same thing we can do with a 10 rupee bent angle needle goniectomy, 10 rupee 26 gauge needle. Studies, we have data on eye stent. We have data of more than 15 years, 1 million implantations worldwide, 300 publications, proving the efficacy, 30% reduction, 25% reduction, maintained over 5 years. That's enough data for us to have faith on these medical devices. 5 years, patients on 3 to 5 medications and medication reduction maintained over 5 years, intraocular pressure reduction maintained over 5 years. That's the counter to we don't know what is going to happen in the future. This is a systematic review, meta-analysis. All the studies are pointing towards the intraocular pressure reduction, which is maintained over 60 months. And the best part is the safety. We are talking about cataract surgery. We are already opening up the eye. We have to go through the same incision, no extra incision, no sutures, nothing. And post-operative recovery is as quick as in a normal cataract surgery. So my practice patterns is I discuss with the patient why we are planning the glaucoma surgery. I explain the patient about what are the surgical procedures, what are the options we have. Filtration surgery is usually required in advanced and high intraocular pressures, but risks involved are also higher. So MIGS is a viable option in mild to moderate glaucomas to slow down the progression, to decrease the dependence on medication, improve the quality of life. Again, a new study has come up with for the quality of life as well. Decrease the need for more riskier filtration surgeries in the future. And if insurance company is covering the cost of the implant, I prefer doing an eye stent. But if not, KDB and Bang are very good options, even suture GAT for that matter. So I started doing my MIGS after the last AIOC. I got the inspiration from an instruction course in the last AIOC. And in 11 months, I've done almost 60 cases, and I'm seeing 30% reduction in intraocular pressure with 70% reduction in the number of medications. Again, so MIGS is not an alternative to filtration surgery. Huge population of mild to moderate glaucomas who are progressing in spite of our medical management. And MIGS can stop them from progressing into severe and advanced glaucomas. We can prevent majority of these patients landing up with a trab or a tube in the future. But yeah, not all mild or controlled glaucomas undergoing cataract surgery would require MIGS. We have to identify those patients who are non-compliant, patients on multiple medications, medications that are contraindicated, or are unable to use their medicines. And the option of MIGS has to be given to these patients when they are undergoing a cataract surgery. This is not only ethical, but it also becomes necessary in the future. The patient will come back and say, why didn't you tell me about MIGS? And MIGS has created a paradigm shift in the management of glaucoma worldwide, and it's high time that we practice here in India. These are the workshops that we did over the last year, starting from GSI to CFS Hyderabad, then AIOC midterm Patna as well, and at our Dwarka center also. And MIGS has been so versatile. I've done it for a 10-year-old guy and a 92-year-old lady as well. Both of them are doing very well. Thank you.
Thanks, Amit. You make indeed a very compelling case for use of MIGS in these patients. Last debate for the day is role of trab versus tube as a first-line surgery in primary glaucomas. And to speak for our age-old surgery, which is trabeculectomy, which is the gold standard, invite Dr. Prashant Srivastav, again a colleague of ours from Shankar Netralaya in Chennai and Calcutta, and now a senior in Kolkata. This also. Thanks.
Thank you, Maya. Good morning, everybody. Thank you, Maya, for making me part of this instructional course. So, as Maya said, I'll be talking about the trabeculectomy as a first-line surgery in favor of trabeculectomy. So there has been debate about the first line of surgery, whether it can be tube or a trab surgery as a primary surgery in the conditions where glaucoma cannot be controlled by medical management. Although the medical claim data shows that there is increasing trend towards the tube surgery, but however, a recent survey done by American Glaucoma Survey Society, the trab is still most preferred surgery in America for the primary cases. Now, why to compare trabeculectomy and tubes for a primary surgery? So I have two questions. Why not to consider trab as a first-line surgery? Is there any doubt about the success of immediate or long-term success of trabeculectomy? To clear this, we have a 20 years follow-up study of trabeculectomy. So John Landers and Keith Martin have done 20 years follow-up of trabeculectomy. So those surgeries were done in 1988 or 1990 were followed for 20 years. This was a retrospective cohort study. And the main surgical outcome was IOP less than 21 millimeter mercury after 20 years without medication. This was defined as complete success, and with medication was defined as qualified success. So what they found that even after 20 years, 57% of patients had a complete success after trabeculectomy, and these included secondary glaucoma as well. And 88% of patients were qualified success. That means the IOP was less than 21 millimeter mercury with medications. The risk of failure was pseudoexfoliation aphakia and uveitic glaucoma. So around 60% of success rate after 20 years of trabeculectomy. So that vouch for the trabeculectomy surgery. So trabeculectomy is a very successful surgery in the long term for IOP control. And the other point, which is in favor of trabeculectomy, that trabeculectomy can be customized based on the case-to-case scenario and also based on the expertise of the surgeon. So one can do a triangular flap, can do a rectangular flap, releasable suture, use of mitomycin can also be customized based on the condition. And surgeon has liberty to customize it and get a favorable result in trabeculectomy. However, in the tube, the surgical steps are very confined and fixed, and one cannot modify it much. There is a learning curve in a tube surgery. So most of us are familiar doing trab from our residency day or post-residency period. Even in United States, Dr. Francis, who was an investigator of tube versus trab study, have failed that there is a mental block or biasness towards TAB because most of the surgeons are not very familiar with doing a tube surgery. So surgeons' comfort and experience is definitely much more in doing a TAB, so that can bring more success to the surgery. And what are the options available if the tube fails in the first place? So TAB is very easy. One can do a TAB surgery. If it fails, one can do a needling. If it completely fails, then one can do a second TAB and then tube, one tube and then second tube. So there are many options available. But what if someone puts a tube in the first place? Then there's no question of TAB, or TAB is very difficult to perform. The next option is putting an inferior tube, and the other option will be, after failing this, the other option will be doing a cytophotocoagulation or disruptive procedure. So options are limited if you go for a tube procedure in the first place. However, TAB gives a wide variety of range. And there is also concern about the tubes. Dr. Francis, who was an investigator of T versus TAB study, felt that many patients are conscious about putting a plastic-like material inside the eye, which they are going to have for their life. Also, if you put a tube in an early case of glaucoma, there is high chances of erosion or extrusion of tube in a longer period. So this is a landmark study of primary tube versus TAB study. This study actually compared the placement of primary tube versus TAB in virgin eyes. So total 242 eyes were enrolled, in which 125 patients were enrolled in tube groups. So main outcome measures, surgical failure were defined by IOP more than 21 mm of mercury or less than 5 mm of mercury. So this is the Kaplan-Meier plot, which showed that at the first year of surgery, TAB has a better success rate as compared to tube. Though after 3 years onward, success was similar in both, but the need of medication or complete success was much better in a TAB group as compared to the tube group. So TAB should be a preferred surgery because it can bring more success to our surgical groups. And there is a role of baseline IOP as well. And this study by primary tube versus TAB study showed that patients with lower baseline IOP has lesser success rate with tube plantation as compared to the TAB. So all the normotensive glaucoma patients, those category of patients will benefit more with the TAB surgery as compared to the tube surgery. So take-home points are, so trabeculectomy has a lower risk of failure as compared to tube shunt surgery, particularly at lower IOP. Baseline IOP is very important in case of primary tube surgery. And also the need of post-operative medications and complete success is much better in TAB as compared to tube surgery. Although tube surgery can be considered in few cases where the patient cannot come for a follow-up very regularly, or the surgeon is very much bothered about the immediate post-op complications and doesn't want to go through the rough patch of immediate post-op period, then only those cases tube can be considered. Otherwise, most of the cases, TAB can be still considered as a primary surgery for a primary glaucoma. Thank you. Thank you.
Thank you, Prashant. Next is Dr. Richa Gupta, and she'll be speaking on role of tubes as a first-line surgery in primary glaucomas.
Hi, very good morning to you. To tell you frankly, when MAYAV discussed the debate topics with me, I misheard it as secondary glaucomas, and imagine my plight when, just few days back I realized my mistake. So I took up the challenge, and because, again, honestly, even I wouldn't prefer doing a tube in a as a first-line treatment in a primary glaucoma. But then I thought of doing some literature search, and Prashant, I'll give it to you, I think, in this topic. I'm just here to discuss and just discuss few studies which have been published previously, and we'll then probably have a discussion after this. So the use of glaucoma implants were limited usually, in cases where trabeculectomy has failed or in cases of refractory secondary glaucomas. But with time, the indications for tubes have become a little less restrictive. So for this debate topic, I had two points to ponder. There were two aspects to it. One was it should be a primary procedure, and secondly, it should be a primary glaucoma. So I looked up the studies, and this was one study, tube versus trabeculectomy, a famous study. But again, the cases which were included in this were already secondary to an incisional surgery. So I had to do away with it. Came across the PTVT study, the primary tube versus trabeculectomy study. So here we have 242 eyes, in which 125 of them underwent tube procedures and 117 underwent trabeculectomy. So these were the pre-op diagnosis. This was the pre-op diagnosis. So in conclusion, there was lower intraocular pressure that was noted with trabeculectomy, plus there were lesser number of anti-glaucoma medications post-op, which were needed in these cases. But then the end result after 3 years was that the verdict was equivocal. And there were more serious complications after trabeculectomy post-hypotomy. So this was PTVT. The same patients were followed up for 3 years again. And again, at the end of 3 years, there were no significant difference between the surgical failure rates between the two groups. And trabeculectomy had a lower IOP with fewer glaucoma medications. Plus, again, the risk of hypotony-related complications were higher with trabeculectomy. So this was another study. It was a two-centered study done in Saudi and Sri Lanka, in which all types of glaucomas were included, and they needed either a primary or a secondary trab or tube. And we did some sub-analysis. So there were 117 patients included, and 62 were randomized to trabeculectomy, 55 to implants. The mean follow-up was for around 10 months. And this was the demographic variables. So if you notice, the primary glaucomas were 83 out of these 117 cases. And if you look at the surgeries which were done, out of 75 eyes with primary procedures, 61 of them had primary disease. So trabeculectomy was performed in 35 of such eyes, and AGVs were implanted in 26 of such eyes. The post-op complications, again, were equivalent in both the eyes. So over the short term, up to 13 months follow-up, the complications and the efficacy of both the procedures was similar. The IOP lowering was greater with trabeculectomy, and success outcomes and all the other parameters were equal post-operative. So the same patients were followed up for another 31 months, and the result is the same. Lower IOP with trabeculectomy during the first year, which actually became equivalent in both the groups at the end of 31 months. No statistically significant differences between all the parameters in between the groups. So the efficacy and complications of both the procedures in a previously unoperated eye with primary glaucoma seem to be comparable for at least 3 to 4 years. And there are many factors which actually decide, which procedure is preferable to a surgeon. Trabeculectomy has definitely stood the test of time. So is there time now to consider extending this offer to implant procedures as well? I would want RG, sir, can you tell me whether you have operated or inserted a tube in a primary glaucoma as a first-line treatment?
Well, in 20 years, maybe once or twice.
Once or twice, yeah. Anybody else in the house who would like to comment?
Developmentally challenged adult, difficult follow-up under GML.
Somebody who's a contact lens user also can.
If it's no other options, then yes.
Anybody else who would like to comment on this? No?
So it's a tough.
So this was a tough case, yeah. But an eye-opener. There have been studies, so I was actually surprised to see all this. Yeah, right. Thank you, Maya.
Thanks, Richa. And with this, we come to the end of this instruction course. If there are any questions, we would love to take them right now. Or if not, I have always questions to ask. 1 second.
I just wanted to ask. Hello. If there's a CRVO case, say, where NVG has occurred, would you all try a trap first before doing a AGV, or directly go to? Thank you.
Would you answer that, Prashant?
For NVG case also, we can try doing a trap. Initially, first we have to see the degree of neovascularization. First, we can give a anti-VEGF 1, and then wait for 4 or 5 days. We can do also, if you have time, then we can do a PRP as well, and then see if the media is clear. IOP can be controlled initially by medical management. And if things are under control, we can do a trap also. Trap also gives good results. It's not that trap will always fail in case of NVG. Many cases it is successful. And if as a second procedure, we can do a tube. Primarily, we can give a try for a trap, but after giving an anti-VEGF.
I think role of angles is important. That the angles are still open, and you've managed to catch the NVG early, start treatment early, and take care of the vascularization of the iris early. The angles are still open. When you think of doing a procedure, at that point of time, doing a trap may give you a better result. But if you have completely zipped up angles and everything is extremely shallow, then probably a trap may fail. Higher chance of then probably doing a primary tube in that case is maybe the correct option, sir.
Just one thing, if you're planning to do a trap, just make sure the patient is going to be able to follow up closely with you. Because you need to put in a lot more work post-op with the fibrofuse and everything else. If it's somebody who's not going to come to you for follow-up for next 3-4 weeks, then a tube is probably a better option.
So my question to you regarding your topic would be that this is a typical case which a lot of us as general ophthalmologists and basic cataract practitioners get, that you have a case probably of pre-barometric glaucoma or a disc suspect where disc is showing us changes. OCT, RNFL and GCC showing us changes. IOPs are always in the borderline range, not too high, not too low. Average pachymetry. Perimetry is absolutely okay. Would you treat? And no other risk factors, no family history. Would you treat? Would you follow up?
Okay, I'll just quickly take this in 2 bits. If your pressures are more than 21, then basically you are saying that this is a preperimetric glaucoma. Or you're saying it's an ocular hypertension who's a disc suspect. And in that category, there is enough evidence to show that if those are the patients who are more greatest risk of progression from the old study of wearables. If your pressures are consistently in the normal range, then you're saying NTG suspect. And at that point, all you have is a dodgy looking disc. So at that point, I would definitely follow up, do structural tests, do functional tests, but I would not elect to start on treatment because many of them may not convert.
Pressures of anywhere between 18 and 21 and perimetry normal.
I would still elect to wait. See, one thing we should always remember that glaucoma is a slow disease. I've got ocular hypertension, I've been following for 20 years, nothing has happened to them. So the point is that you follow them up closely, tell them that they have a problem. And at the slightest hint of trouble, you treat them.
For OCT, how confident are you that whichever scan you are seeing is exactly at the same place, depending on what machine you are using?
Yeah, so again, as was shown in the presentation, it should be a systematic approach. Look at the clinical picture also. Disc photography sometimes, a baseline photography also helps. Basically, progression becomes more significant, and look for artifacts. If there are artifacts and if it doesn't correlate with the clinical picture that you're seeing, considering that OCT has a high false positives, probably you can wait and redo the test and then decide on treatment.
Amit, for your debate, we spoke about glaucoma controlled patients. What if we have somebody who is progressing? What do you think are the intraday fluctuations which happen in a case post-mix? Because that's one of the main reasons why we're doing a filtration procedure, where you want to keep the fluctuations as low and as possible. So in a case who's progressive, what is your take on role of mix? And if there's any particular mix do you prefer in these situations?
Yeah, progression, there's a new study that has come up which has shown very less progression. See, I think we need a study to see the changes in DVT pre and post MIGS right? So that is not there.
Thanks. Arji sir, can we just take a photograph, please? Just all loudspeakers here.